Thank you again for having me. I'm Sean Connolly. I'm a pediatric cardiologist at Nemours, primarily a clinician. I think some of the research and other things like that I've been involved in are certainly related to sudden cardiac arrest, preparedness in schools, like we'll hear about here, and as well as an interest in preventive cardiology. So I do some work with Dr. Baker Smith from that respect in terms of research, but primarily I'm a clinician in this field, and the interest here is born out of a lot of things, but really just my interest in advocacy and involvement in community, and this has been a great avenue to do that. And so I'll explain this project. I understand time is limited to some extent. I was told to keep this to about 5 minutes, and I'll try my best to do that. Please let me know if you would like me to kind of move on a little quicker, but I hope this kind of tells the story. I'm the cardiac safety panel for GSK. This has nothing to do with this at all. The scope of the problem in this regard. Oh, sorry. Can you see? All right, you're still good. Sorry, I'm trying to minimize this. Out of hospital sudden cardiac arrest, about 350,000 events occur in the US per year. This is including adults and children. In children, it's about 2 to 6% of these events occur in kids less than 18. So that's somewhere between 7 and 23,000 out of hospital cardiac arrest events that occur. And survival overall is really poor. So we quote roughly about 10 to 12% of people survive out of hospital cardiac arrest, and the neurologic outcome is even worse. When we think about this from a clinician perspective, as pediatric cardiologists, I think that we understand that we see otherwise healthy appearing children who may have an undiagnosed at-risk condition that might put them at risk for sudden cardiac arrest. And our job collectively is to try to identify those individuals and mitigate that risk so that they don't have a cardiac arrest event. And a lot of that's done, that's really primary prevention. So that's through identifying these individuals and mitigating the risk, and some of that screening. And there's different ways in which we screen, but ultimately we want to eliminate a sudden cardiac arrest event from happening in the first place. Despite our best efforts, these events occur, and they will occur. We don't really have the perfect screening mechanism, and so a lot of the work that we're interested in and we think is really important is the idea of secondary prevention related to CPR, AED use, and specifically cardiac emergency response plans. We think that can influence the likelihood of individuals surviving those events and surviving without comorbidities or unfortunately resulting in sudden cardiac death. So a lot of what we're interested in is cardiac emergency response plans, which really gets to this core of what the American Heart Association has touted for decades now about the chain of survival. And in particular, in out-of-hospital situations and scenarios, this is about recognizing that a sudden cardiac arrest event occurred, starting high-quality CPR, and using an AED. A cardiac emergency response plan is really a written document that establishes these steps that reduces sudden cardiac arrest. And particularly, we think about this in settings in which these events may occur, like schools or other sporting events in particular, like rec leagues, and places where people go often and the same people kind of congregate, and a place where you can develop a particular specific plan in case these occur. A cardiac emergency response plan sort of comprehensively involves not just the written document, but it really involves all of the components of this. So making sure you have individuals trained in sudden cardiac arrest, performing CPR using an AED, that you have a team that you've identified, that within these spaces you have AEDs and that there's correct placement and maintenance of them, that you've communicated the plan to everyone involved, that there's adequate training in CPR and AED use, and that you've run drills, and that you've involved local EMS, and that you're reviewing this on an annual basis. So collectively, when you put all of this together, we think that you've sort of met that threshold for criteria for having a really solid plan in place, and that likely you're going to have a higher likelihood of survival if an event were ever to occur in that area. These have been shown to be effective in several studies. I think probably the most cited is back to 2009 with Jonathan Dresner in Seattle, Washington area, and they effectively showed that school-based cardiac emergency response plans increased survival rate to almost 64%. For students and non-students who had sudden cardiac arrest on school grounds. So if you think that overall survival rate is about 10 to 12, if you increase it to 64%, this is substantial. In Delaware, as I can certainly talk about this in a minute, but we were starting a program that really was implementing cardiac emergency response plans in schools. This hadn't been done in the state before. And so we thought this was a good opportunity to sort of see where we stand. And so we wanted to start a pilot project that did several things. One, it helped us understand sort of the landscape of cardiac emergency response preparedness throughout schools in the state. We obviously wanted to use this data to help plan our program initiatives, to do and sort of support the work we do from a legislative side and advocacy, and really to ensure that we're providing equitable service allocation throughout the state. So you'll see sort of how we took that. We also wanted to study the long-term impact of our Project Atom organization, which is a sort of the umbrella under which we work as a cardiac emergency response plan advocates. And we wanted to better understand neighborhood level barriers to cardiac emergency response preparedness. So one of the things that we use to sort of begin to understand better the neighborhood level differences in cardiac emergency response preparedness was a metric called the Area Deprivation Index. And this lives it's called the Neighborhood Atlas. This is done through University of Wisconsin, and it really ultimately provides geospatial or geocoded description of neighborhood disadvantage, and it involves 17 specific variables that you see sort of over here on the right. And it's pretty amazing and pretty interesting to use. And you kind of see the different color-coded segments of the state of Delaware, and areas that have the highest number, the highest area deprivation index, and are in red are sort of the areas that are most deprived based on this data for the census block data. The ones that are in blue and deep blue are least deprived. So a lower ADI is considered less deprivation, or a higher sort of socioeconomic area, whereas a red is worse. Ultimately, we understand or thought that students who live within high neighborhood level socioeconomic disadvantage areas and attend schools that have higher deprivation are at greater risk for experiencing poor outcomes following out of hospital cardiac arrest, and there's plenty of data to support that. So our aims for this particular project were, one, to identify which elements of that cardiac emergency response plan are really present in schools throughout the state. We wanted to compare the proportion of low, medium, and high ADI schools with ultimately a complete cardiac emergency response plan, so all of those elements, and to compare the proportion of low, medium, and high with the individual components of the cardiac emergency response plan as well. Ultimately, we hypothesized that schools within high compared to low and medium deprivation neighborhoods were less likely to have core elements of the cardiac emergency response plan in place. And so we performed a statewide electronic survey of all schools, public schools from K to 12 in Delaware from January to May of 2025. We developed survey questions that were really chosen to represent each of these elements of the major elements of the cardiac emergency response plan that we saw a few slides back. And we used the geocoded national ADI scores for all of these schools based on their zip code and categorize them, which has been done in research in the past, that it kind of helps us look at, define schools that may be in low area deprivation index neighborhoods versus medium and high. And ultimately, our results to date are that we had about 50% schools that participated, so 98 schools. 0 schools had all 7 elements of a cardiac emergency response plan. About 81% of schools reported a minimum number of AEDs for school size, and I'll elaborate on that a little bit. I think the question asks, ultimately, do you have enough AEDs that you can get from a victim to the AED and back within 3 minutes? And so 81% of schools said that they had that. I think that there's a little suspicion about whether or not that is entirely true, but at least from the data results that we have, 81%. 22% of schools reported the minimum staff was trained in CPR and AED. About 9% of schools said that they had a written cardiac emergency response plan. And overall, there was really no difference seen across low, medium, and high area deprivation index schools. A few limitations to this, I think probably several in the end, but ultimately I think we still get information that is really helpful. But overall, relatively low survey completion rate at about 50%, particularly low survey completion rate by high ADI schools. So there's only 10 schools that of that high area deprivation index that reported back, compared to 27 from low and 61 from medium. And there's a potential for some inaccurate responses based on the survey respondent likely being unaware of the details of each of these SERP elements, despite our best efforts to kind of make that clear in the questions. But in the end, I think certainly the take homes were that these response preparedness plans in Delaware state schools are poor. Most schools do not have a cardiac emergency response plan. And at least based on this, neighborhood socioeconomic status is really not associated with a lower likelihood of K through 12 schools having a SERP. It was just poor across the board. And we think that's probably true based on what we understand about other states throughout the country as well. Again, despite some of the limitations, this theme about decreased cardiac emergency response preparedness in schools being poor is really consistent with other work that we've seen. AED availability in this case is higher than expected. Again, like I had said, I think some doubt remains about the accuracy of the responses here. And I think that without a doubt, there's a significant opportunity for healthcare providers and others to work with communities and schools and our government at state and national level to help encourage cardiac emergency response plan laws. And so we're doing several things. You submit this particular abstract for presentation at the Nemours Research Day, as well as the AAP conference in San Diego in October. We'll write this up in a manuscript and publish this data as well, and continue to sort of build on this. Certainly are using this data to support advocacy efforts. We're doing that as we speak in terms of advocating for cardiac emergency response plan legislation in the state of Delaware, and currently working with colleagues at Indiana and CHOP to sort of build on this particular project and try to learn more and get better data overall. Several people to thank. Certainly Chris has been huge in this. Carol, Jorge, and Bridget, Karen McCandless, and Amy McCullum are program coordinators for Project Adam, the American Heart Association, and the people who work with Project Adam. Just a quick plug, I think that Project Adam is this organization that I'm the medical director for, that we go into schools and help them implement cardiac emergency response plans. And we've done this now in several schools, and we continue to work with numerous of them. This was our first school that we honored with a banner that sort of completed each of these elements and is a much safer place to be every day. And if you or anyone has any interest in reaching out to us, please email at projectadam@nemours.org. And we'd love to work with you and talk a little bit more about how we can help. And that's it. Thank you.